Hi, I'm Dr. Janet Pope. I am tweeting or on X as at Janet Burdope, and I'm tweeting on behalf of at Room Now. This is hashtag Eular 2024 in Vienna. In this study, I'd like to tell you actually about a randomized controlled trial. So what's the background of this? This is a scleroderma study over 1 year, and we already know that rituximab in systemic sclerosis can help both skin and in interstitial lung disease. We also know tocilizumab helps skin a little bit from the two tocilizumab trials, and also it might prevent worsening or new interstitial lung disease. So this was a small study and really, in a way, could have been underpowered. What were they asking? It was a 1 year biopsy-driven open label phase 4 randomized controlled trial. And they wanted to find out superiority of rituximab or tocilizumab in scleroderma ILD, looking at half a year to a year, so two different endpoints, after they had already failed cyclophosphamide. So this was a 1-to-1 randomization. And this study was unique because they did lung biopsies and they said you were either B-cell poor, so maybe rituximab wouldn't be good in that group, or B-cell rich, where rituximab might be better. Interestingly, half the patients approximately, or 32, were B-cell poor, and half approximately, or 28, were B-cell rich. So what they did was they got either randomized in either group, 1-to-1, rituximab 1 gram IV times 2, and then they were followed, or tocilizumab, an interesting dose, not 4, not 8, but 6 milligram per kilogram IV every 4 weeks. They wanted to look at an improvement in the forced vital capacity and a change in the high-res CT scan of their lungs and the skin score, the modified Brodmann skin score. So there was no difference in the side effects. 7% had AEs or serious adverse events on rituximab and 10% on tocilizumab. But there were differences. B-cell poor patients, I bet you would guess that rituximab would have less of a response than tocilizumab. Absolutely found. However, the opposite was found if they were B-cell rich, where rituximab was better than tocilizumab. And if you looked at the groups together, my estimate on looking at the percent change in FVC, percent predicted, it would probably be about the same in the two groups, but the responders of B-cell rich were more rituximab, the responders in B-cell poor were more tocilizumab. So what is our take-home message? Number one, when you fail cyclophosphamide, if that's the order you're treating scleroderma ILD, either rituximab or tocilizumab could be effective. Number two, if you actually knew on a skin biopsy or maybe a biomarker in the serum, or in this case, a lung biomarker, a lung biopsy, if they're rituximab responders, they are more apt to be high in B cells. If they're tocilizumab responders, they're more apt to be low in B cells. The third thing is that when we're actually treating patients, we will treat on access, what we're used to doing. And right now, this biomarker is not feasible, but I think it's a first step in personalized medicine. So your take home in this is you might use rituximab or tocilizumab. We tend to use it after MMF, adding it or switching to it. But the B-cell rich population, no surprise, would be helped more by rituximab. If they're not B-cell rich, then tocilizumab would be better. I hope more will come in this space to help us treat our patients where there's huge unmet need. Please follow us for more reporting at Room Now. Thank you.